Welcome everyone to our journal club. This month we are talking about the brain because the brain and the vestibular system are connected in so many important ways. And very specifically, we'll be talking about cognition and the benefits of dual task rehabilitation. So for that topic, we have with us a wonderful expert in this area. His name is Dr. Mike Studer, and he has too many initials for me to say, but I'm going to let him introduce himself a little bit more.
Very simply, I am just a very passionate clinician who loves everything about the brain, and dual tasking is just one specific element that I have studied and practiced in depth. Thanks for letting me be here.
It's our pleasure. So we're going to get into our slides so we can start talking about the article, which is Making Balance Automatic Again, using dual tasking as an intervention in balance rehabilitation for older adults. And since we know that the vestibular system is a key element of balance, it makes sense to kind of tie these together and explore. So let's get into the slides. I always start our journal clubs. For those who have watched them all, I'm sorry for the repeat, but I never know who's coming on for the first time. So I always start our journal clubs with a very, very brief introduction to the vestibular system to make sure everybody is on the same page. So our vestibular system is our wonderful inner ear balance sensor. We have one on the left and one on the right typically, and it sends information to the brain. And the brain has a big job to integrate information from our inner ear balance sensor, along with our vision, our joint sensing information or proprioception, information from hearing, and so many other pieces of information that the brain takes in about our world to try to orient us and kind of let us know where we are, not only our personal balance so that we're not unexpectedly leaning or falling to the left, but also our sense of space in the world. They call this spatial awareness. So what we know about the concern of falls, which is how this article that we'll be discussing tonight starts, is that unfortunately nearly 30% of people in the United States over 65 fall at least once per year. And there's a lot of discussion over kind of causation of falls, and what they've found in the research is essentially it can be multifactorial. So we have concerns about the person's individual status, things like their medical problems they might be experiencing, whether that's cardiac issues, pulmonary issues, vision issues. There's things that can be somewhat influenced, like medications, which maybe we can change or adjust because they're contributing to imbalance or dizziness. Also considerations that are kind of part of the environment. So is that what footwear they were wearing? I am not a fan of flip-flops. I've had too many patients fall in a flip-flop. Outdoor environment issues like uneven ground, and just a host of factors. And unfortunately, as your article points out, Dr. Studer, it's certainly a physical issue. We're worried about the safety of our folk and them not getting harmed, or a serious injury or death actually can result from a fall, unfortunately. But also the broader society does have to be concerned about the cost of a fall, which has been cited in the thousands of dollars per person. So that's quite a few falls. You multiply that out, that's a lot of money as well. So is there anything else you want to add about falls risk factors here?
The only thing that I would add here is that when I look at data and statistics on the average cost of a fall, we do see that some citations will bring that up toward 11 and as much as 16,000, because we sometimes are going to have hospitalization, hip pinning and etc., rehabilitation after. So this is a very conservative and obviously appropriate estimate by these authors. But usually that is just going to be handling the very acute emergency room. And if you're talking $1,300 to $1,800, that is it is going to be a microcosm of what the average fall actually has. So I love the slide. I would say the dollars most frequently are upwards of 15,000, 16,000 though.
Right. So yes, we do not like that. That is of concern. In addition, it is true that cognitive impairments are tied to falls risk through reduced attention. And this can impair our ability to do a dual task, which many people would characterize as two things at the same time. We'll talk more about what dual task really is defined as in a couple slides. But I like this image because you'll see it quite frequently in different formats, indicating how the vestibular system and our vision and our proprioception are coming into the brain to give us information. And realizing that the brain, in my analogy, is like a big computer. So not only is it taking information from those sensing organs, but it's simultaneously supposed to be doing other jobs, right? Whether that's the autonomic nervous system, heart rate and blood pressure and oxygen, but also, other kind of higher level tasks, thinking about what we're going to have for dinner. So there's a lot going on in that brain at any given time. And in the same time, it's going to result in us, kind of taking in our environment through eye movements and trying to maintain our balance. So when we think about dual task tolerance, it is related to falls risk. And balance rehabilitation should include and, consider kind of all of the demands that life really has. It troubles me when patients will tell me about kind of ways they've been trying to work on their balance, perhaps independently or at prior rehabilitation in the past, where they kind of describe, I was standing on one leg and then I would just keep trying to stand on one leg. That is such a small piece. I mean, it's not that it's unimportant at all, but it's such a small piece of what balance demands. For example, there's no turning of the head there. That's huge, at least from a vestibular standpoint. So we're thinking about, kind of the kind of factors we're going to discuss today. We're going to really hone in on vestibular activities and tying that into cognitive and dual task activities. So something that I have experienced, and I imagine any person out there who's rehabilitated patients, particularly patients with vestibular issues, is a report from a patient that they experience memory loss or a sense of brain fog, mental confusion. And they're like, I wasn't like this. I was sharp as a tack. And ever since I had this vertigo event or, vestibular neuritis, concussion, I forget things. I'm taking notes and then I kind of forget what I was going to write down as I hear it. And they're so frustrated by this and they don't understand why it's happening. But I explained to them, and you might know this as well, Dr. Studer, that there is actually a 4-fold increase in cognitive impairment for patients with vestibular disorders, with 12% reporting limited mobility due to memory problems or confusion. So that's a pretty significant change. And I try to validate the patient, and then it just makes me know that we're going to have to work pretty hard on these elements to try to kind of compensate, to try to make up for some of these issues so we can reduce that impairment. Maybe I can't eliminate it, but I would like to at least maximize what the patient can do. And I would be interested to hear your input on this as well, Dr. Studer.
Yeah, and I think that is really the crux of our discussion today. And I think that's going to be the most engaging things for your audience here, to really try to understand what's happening here across the spectrum of vestibular disorders. All right, well, with concussion, that's going to be pretty obvious. Both systems might be impaired, right? So that's an easy one, cognitive and vestibular. And the other things to consider is, are we experiencing a resource allocation problem? Is the vestibular system just demanding more attention because it's no longer running on autopilot? Is that borrowing from cognition? So I think the listeners will be certainly engaged to hear our thoughts on that, and to get to some conclusions that may even lead to some interventions and or compensations.
Absolutely. I 100% agree. So what they have found in the literature as a summary, and there's many studies and more to come on this, is that a vestibular dysfunction, which may be a vestibular hypofunction, which could be bilateral or unilateral, could be a vestibular issue as a part of a concussion. Remembering that concussion can involve many brain pathways, and so the patient may also have visual complaints, eye misalignment issues, difficulty with emotional processing. There's a lot of elements that one might see with concussion. It certainly can be multifaceted because the brain is the main event there that's been affected by the issue. And then even in something that you might think would only be mechanical, these BPPV or little tiny crystals we have in our inner ear that can go out of place. And certainly in patients with persistent postural perceptual dizziness, vestibular migraine, essentially almost any vestibular condition you can name has been linked with some sort of cognitive challenge. And examples can include spatial memory, navigation, mental rotation, mental representation of three-dimensional space, and particularly of interest to us today, attention, cognitive processing ability, and dual task. And there was a specific study on dual task in patients with unilateral vestibular hypofunction showing limitations for that group versus an equal group of healthy controls, meaning they otherwise matched on gender and other elements. So it's very important that we consider what cognitive limitations might come up because of a vestibular issue and train that appropriately in a variety of vestibular issues. It's not only concussion, which I think is perhaps the one that's more common or might kind of be more obvious because patients are most likely to report kind of difficulty with attention and things of the cognitive nature after concussion. But we can see it even if the patient might not report it, but if you kind of check in a little bit, they might admit, yeah, I've been forgetting where my keys are more, and other kind of signs that they feel their cognition is not quite up to its usual par. Mm-hmm. So big question that we're going to try to answer. But unfortunately, the literature is still growing in this area. So we know there's a limitation. Can training really improve cognition and balance in the context of vestibular rehabilitation? So this photo is pulled from a video I found online. It had a nice example of someone doing a reaching task. They've got cones with golf balls on top of the cone, which I thought was a cool idea. So you have to keep the golf ball from falling out of the top of the cone while you turn and reach to move the cone from one side to the other. From a vestibular standpoint, I love it because it's got turning, which is a nice way to stimulate some vestibular activation. So that appealed to me. And there's a very cool study that's in process as we speak called To Balance. It's out in Belgium. And they have run through so far their young adult protocol. And then they're working next on some people with pathology. So unilateral and then eventually bilateral vestibular hypofunction are the groups they're going to look at. And they're going to look at kind of integrating true cognitive rehab inside of vestibular rehabilitation activities, which I think is really cool. So I'm excited to see the results of the group with pathology. Of course, they had to do normals first to kind of find the norms and to see if all of the tests really kind of were touching on what they wanted them to touch on as far as different pieces of cognition that they were assessing, as you can see here, like working memory and things like that. So so far have published 2 layers, where first was the protocol, their plan, and then 2022 they published the young adult norm study, and so now I believe they will be working on their pathology group. So hopefully in another few months, a year, I don't know how long it will take, they'll get some results for us to start to really see what impacts we might be able to have and what specific techniques really could work best. Right now, I would say it's a bit of a guess. I'd be interested as to your input on that, Dr. Studer.
Yeah, it will be interesting. I love what I'm seeing here from the continuum because, Helena, as you recall, one of the specific things that I like to bring to the dual task world is that it's not always represented by cognition, right? And so it's nice here that we do have some spatial rotation, some working memory, some problem solving, some response time. And then beyond that, we have to think, okay, cognitive, manual, visual, and auditory. So I'm always enamored by more tests, instruments, screening tools being added to the dual task realm, because we all know that we've lived literally for decades feeling like we can definitely come up with the cognitive timed up and go, and we have a hard time coming up with too much that's standardized thereafter. So I'm looking forward to getting into that discussion, but the modes of distraction are not necessarily representing one another. So because someone tests well on cognitive, does that mean necessarily that they'll test well on the other three? Likely not. There appears to be some specificity.
Absolutely. No, it's great to think about, especially when we think about our patients who are post-concussion athletes and the idea of, return to play and what kind of dual tasking they might need to be able to do, similar and or different than a 45-year-old woman who has 3 kids that are a constant distraction. So there's a lot of different experiences and challenges and demands on different people in different environments. And so kind of how can we do some specificity of training, which is usually in the literature overall well recommended for our patients.
You've got it exactly right there. I mean, that is the crux. Number one, how does this person test? So what types of dual tasks are they not able to do? And number two, equally important, what does this person need? So I love how you've pulled that together. Thank you.
Yeah, well, when you see a bunch of patients, you start to recognize the patterns, I hope. So yes, even the literature coming along will be exciting so we can get a little more detail and maybe some surprises. I'm always open to being surprised by the literature, but it'll be really cool to see. So let's talk about what is a dual task. And so it's defined here in your article as an operation that has 2 or more tasks that can be performed independently as a single task and have distinct and separate goals and yet are performed simultaneously. So you're gonna kind of dig into a list here now on your next slide that you made for us that talks about what tasks and functions we expect to be automatic. And I love the questions below. How do they become automatic and how are they made to be automatic again? So I think about a 2-year-old. So, driving is not going to be an automatic task for them as yet, right? They haven't, that's a novel skill. So we want to make sure that testing, for example, would reflect accurately what we could even expect us to be normally automatic for a person, right?
Right. Yeah. And, that's great. And I love to think on my feet. So you're talking about a 2-year-old right there. And I know your kids are now significantly older than that. But we think about in the realm of a 2-year-old, where running is now starting to become automatized. That's a great, caveat. It's a great effort right there. And if I go up to like 3 and 4-year-olds, I start thinking about, well, is tying their shoes automatized already? Brushing their teeth automatized? So we really have an opportunity across the lifespan, not to be ageist, but to see what is relevant, what's to be expected, what's remaining, and what does this individual's life experiences have in store for them. So if we jump down to the bottom questions, let's give the audience some value here, because it's very tempting to think, well, every task becomes automatized by the number one answer is going to be repetitions. However, that's not why we're here today. And that does not appear to be the answer. The answer appears to be, takes intensity. I'm only going to automatize things that I have tried to practice with a degree of perfection, skill, accuracy. So it takes intensity, no surprise there. But what is surprising is it actually takes a constraint, right? So you'll only be able to proceduralize something down into the basal ganglia and cerebellum if, in fact, your dorsolateral prefrontal cortex, your main attentional regulator, has been constrained. So when we tie up your DLPFC, tie up your attention center and say, nope, you can't use it, that's what actually forces a repetition to become automatized. So I'm busy watching these people, seeing their reactions, and still as a 12-month-old trying to walk. Can't do both, but the reason my walking becomes automatized is so that I can see these people, can chase after my dog, can carry my toy. So it requires repetitions, no doubt, requires intensity, slight surprise there, but the constraint of the attention center is critical.
That's really interesting. All right, so we go on to think about different contexts. So here is a slide about athletes and things that could be automatic for them, like shooting a free throw. And I would say that, again, if you're looking at an athlete, you might say to yourself, well, what's automatic for that athlete for that level of skill, right? A professional
Mhm,
versus, a novice, for
mhm.
example. Um, and I would be interested to know, as far as, since concussion is the most common kind of topic around sport, regarding cognition and some limitation there, um, what would you say when you're trying to do a rehabilitation strategy? Can you start with the complex, with, oh, here comes like someone that's going to try to take the ball from you, and you have to go this way and that way, and there's sound of the crowd, that there's a lot of, it could be, I call it triple, quadruple, right? Not necessarily just dual task, right?
Right. So it becomes into multi. Mhm. Yeah.
Right.
So what's interesting there is that if we go back, and we don't have to go back in slides, but you brought up some beautiful things about 7 slides ago where we said, really that preponderance to lean
Mm.
directionally will affect attention, cognitive performance, and dual tasking. So to answer your question here on this slide, what we're thinking about is when there are a multitude of distractions, my coach is yelling in a play, fans in the audience, or some of them yelling for me and some of them are for against me. I've got teammates calling for the ball and I'm watching the clock. So we really look at that in terms of the skill of prioritizing attention. So we don't worry so much about the fact that that is a multiplicity of tasks and stimuli. What we think about is the athlete able to prioritize attention and also selectively attend. So two skills have to happen there. I have to prioritize and I have to filter. And you can call filtering attention one of the main 4 or 5 types of attention, depending on how you divide them out. So that is selective attention. I can extinguish the opposing crowd. I can extinguish my supporting crowd because they're not salient to my performance right now. And so then you come back to your question about how do we rehabilitate the athlete? It always comes down to the same 2 things that we talked about 4 slides ago. Number one, how does this individual present? What are they demonstrating intolerance of? And number two, what do they need? So it's what do we see in them and what do they see for themselves? So we find out, oh, you're intolerant of handling auditory distractions. Let's load you a little bit in that. And then let's consider in your environment, your sport, what do you need to be able to handle? And that's how we make the programming. What do you need? And what are we seeing?
Absolutely. And then the final critical element to me, or maybe not final, but one I think of right away, is what we in vestibular rehab have, I've heard, called grading, right? So I'm going to do
Oh,
a
yes.
graded implementation of stimulus. So if I know that the athlete is going to need to tolerate multiple auditory stimuli while they're performing a free throw, I would not, in my rehabilitation, where they are really sensitive to sound in the beginning, start with all the sounds, right? I'm going to start with just a little bit of sound, and maybe we only do a task for 30 seconds and then we take a break. And so the ability to try to, I always equate it to muscles because people seem to understand muscles better. If I want to get really strong, really buff, I can't start with 500 pounds personally. I have to start with much lighter, and then hopefully over time we can build.
Yeah.
And so we're
Yeah.
really trying to appropriately load and pace. And that's, I think, where a guided professional can make a big difference. Would you agree?
Yeah. I would. And you know what? I would even tie it back. We think about memory chunks, things that are easier to learn. I would tie that back to the considerations of habituation, which your audience is extremely familiar with. Let's not lose track of the fact that when we systematically load and expose an individual to distractions, that one of the things that we're doing is making them more tolerant of distractions. Those are very subtype specific type of distraction. But as you suggest, give them 30 seconds, take it away. What's that sound like? Do 3 to 5 head rotations, then stop. We want that same type of habituation schedule to occur, because that's physiologically what's happening is they get more tolerant. And let's just add the consideration of gamification. So you're able to dribble down the soccer pitch or basketball court with your respective ball. Here's your single task. Here's your speed doing it dual task. And here's your speed doing that when we're adding on some decision making along the way that you have to interact with. So you can gamify it, help them see that they're making improvements, and that increases intensity, attention, dopamine, and it's always very good to be very task specific in that regard. So they love to see themselves measurably improve.
100% agree. And so this can apply just as equally, for those of you who don't work with as many athletes, to any patient. So we're really looking at what does their life include? What do they want to get back to? Whether that's as simple as, being able to put on a shirt, kind of a basic task they've been doing, since they were a child, but now are having trouble with, all the way up to, something a little more involved, like winning a game of backgammon. So there's a lot of different goals that a patient might bring and say, I'm having trouble with this, I'm having trouble with that. And kind of thinking about what kind of task is that? What kind of dual task does that involve? And then trying to tailor, I would say, treatment to that, rather than just say, okay, count backwards by threes. Well, if this is really a manual task, they want to be able to carry, 2 grocery bags while they negotiate through the parking lot. That maybe that counting backwards by 3 is not the right match for treatment. Would you agree?
100%. I would not need to elaborate. I love how you've covered that. And so I'm in full agreement.
All right, cool. So this really is what you highlighted a slide ago or so. Repetition, and then kind of being able to really focus on prioritization, right? So kind of having them be able to handle and ignore distractions when appropriate. Is there anything else on here that you didn't talk about yet that you want to?
No, I want to reiterate one thing, because it can be very helpful for clinicians to have analogies for their own mind, and also to deliver educationally. And so there's 2 things that come into play there. There is the computer analogy that you let us off with. What window do you have open, and what window are you prioritizing right now? So we want clinicians and patients to realize there can be many windows, but the most important thing is that you're prioritizing the window that's going to keep you physically and psychologically safe. The second thing to think about here then is, just with regard to other analogies, is that you can think for yourself or talk to your patients. It's like we're actually putting a sling around, we're constraining, we're taking up all of the resources of your cognition, so that other centers of your brain are the only ones left to process this task. So I think of dual task training as constraint-induced training as well.
Makes sense. I like it. All right. So this slide seems pretty critical. Kind of, how do we improve this divided attention or dual task training? So if you could just kind of highlight what's on here that you think is most relevant, I'm interested.
Yeah, and it's nice to have as the slide here, because we've talked about these things. So it's nice just to summarize. So let's keeping in mind that when we interfere, that is, introduce cognitive motor interference, it gives us an opportunity to be able to see, how does this individual respond? Are they aware that they're leaning or not? So we get to see their insight, and that's that awareness, and it provides them a chance to see, oh, wow, when I'm distracted, I'm at higher risk for falling. So that's the bullet point number 1, is we get to, and they get to, have a window into some awareness. Number 2 is exactly what I've been saying, and I won't reiterate it. We want to load up attention so that procedurally, balance and walking are happening without the contributions of attention. Number 3 and 4, hey, let's keep it task specific. Let's keep it externally focused so that it's engaging, it's gamified, it's measurable, and it's translating to real world. And that's really everything on this slide.
Absolutely. So I think this is a good little story segue. I have to talk about my patients because they're awesome. So I have a patient right now. He's wonderful. He unfortunately has bilateral vestibular loss, pretty close to complete. He does have a little bit of preservation on one side. So he does get a little bit of dizziness, which is a downside to having preservation. But on the upside, he has a little bit of vestibular information he is getting, but it's very limited. So he's the kind of guy, he closes his eyes and it's real tough for him to know where straight is. We'll put it that way, even standing still, let alone trying to take a few steps. And so prior to this loss, he was walking without any device. Now he's on a rollator. He really wants to get back to walking without a device. And so I had a test set up for him where I had put out these number circles that I like, get everything on Amazon. It's all usually for children or teachers who are teaching children or whatever. I don't care. So they're Velcro numbers that you could stick on the floor and they would stick to carpet. And so I put them around the room, but I didn't put them all on the floor. I put them like maybe on a table or even up in the cabinet and things like that. So he has to find the numbers in order, pretty straightforward in a way, cognitively. But there's a lot of head turning and movement to try to scan to find these, right? So that's a very highly challenging vestibular activity for him. And luckily, he's far enough in his rehab. We've really tamped down the dizziness piece. He's got that pretty well managed, but the balance pieces still can be tough because even though I've emphasized to him, you have to think about how you're moving first before you worry about the task, because his automatic pilot is definitely broken. When he turns his head, his vestibular system can't tell him, oh, you're here. So he really has to feel his proprioception. And that's hard to make automatic. You're really resetting the sensory systems at that point.
That's right.
Because you don't have the data really from that sense that used to give him a ton of information. So it's a really big change for the brain, right? And he's in his 70s. So presumably for all of the rest of his life, he was using that information. Now it's suddenly gone. And even though it's been a couple months, that's really nothing compared to his 70 years of life, right?
And
So
you don't gradually feel those senses and sensations, even if it's just the vestibular system or it was just your eyes starting to lose some sight with macular degeneration. When it's insidious like that, the brain doesn't take over and see those small changes and replace with other sensations. So we feel like we've got a period of loss in there, and that's great that you're challenging him to be able to re-automatize, because that's the crux of his functionality and staying safe.
100%. So, I've told him, look, eventually, hopefully we'll build a new automatic pilot where your brain knows not to even bother to check with the vestibular system too much because it's not going to get much information there. But for now, you're going to bend down and grab that number and you're excited. Oh, I got the next one. And you don't kind of think about where your feet are and they're a little too close together and you kind of shift a little quickly. You're going. So, he's through that kind of repetition of trying to reach all those different directions. So there's variety, but within kind of a confined task. And I told him, look, like, remember when you told me last week you were doing good and you've been trying to walk around your apartment without the rollator, but then you turned to go answer the phone because it was ringing and you almost fell. This is what's going on. So
and you're doing bullet point number 1 for him right now. You're seeing his awareness of how delayed he is in recognizing when he's cognitively engaged, recognizing what's happening with balance. You're recognizing that, and he's recognizing and learning, hold on, I got to have a little attention saved back here for what's happening with my balance because I'm not detecting it quickly enough. So I love the fact that you're not only using it as a tool for insight about him, but for his insight about himself.
100%. No, it's very exciting. And I hope that folks out there, who might say, gosh, I just had this patient practice this activity and they just didn't get better. But what insights are you giving them? And this is not a judgment to therapists, by the way. This is something that, maybe we didn't always get enough
Just
or
opportunity.
realize.
Yeah.
Right. Yes, it's totally a chance to say, like what, there's a fine line on cueing, right? We talk a lot about, what does the patient need to learn through kind of a experience versus what do they need to learn through me explaining. And I think there's definitely kind of a Goldilocks. You try to figure out what's the right amount there. But if you see a repeated failure, I think that is a great opportunity to try to maybe just give a bit of insight on what might be going on at the patient's level of, kind of understanding.
Yeah, exactly.
Awesome. So let's talk about the details, kind of modes of dual tasking. So you kind of alluded to this a little bit, but why don't you kind of give us a little more insight here?
Happy to. So I'm going to start at the bottom with manual, and I think that's very straightforward. Pulling a pair of glasses off of your head and pulling a Kleenex or other kerchief out of your pocket and walking. So handling something, and it can also include your feet. And recall that texting while walking is obviously right there too. Manual is straightforward. Visual, obviously a little bit more challenging for some of our individuals that are head rotation intolerant or have concomitant loss in oculomotor in any realm. But remember, visual will always include my ability to scan, interpret, perceive, and prioritize what's happening in the world that I'm moving through on a bike, on a wheelchair, while I'm walking, or even while driving. And then let's move up to auditory. Very straightforward, but let's keep in mind that auditory can be external and it can come from, a traffic light that says walk now. It can come from a honking horn. It can come from communication forms. Auditory isn't always verbal communication. It can be mechanical and machine-based signals, sounds, okay? And then let's go up to cognitive. And when we go up to cognitive, we say one thing. Number one, all of the others that we just talked about definitely have cognitive contributions. The point is that they're primary auditory or visual or manual. Everything has cognition. The only thing that's listed in the realm of cognition is things that don't require the others. So that can be internal thoughts. Pain is distracting. Fear of falling is distracting. Of a mental list that I have to go through in the grocery store is a cognitive, because it's not auditory, it's not visual, and it's not manual. So cognitive gets all of the rest, and it's so explosive. And we'll talk a little bit more about this, but I divide cognitive into short-term working memory, recall from long memory, active problem solving I'm doing right now, and then generating new thoughts that I have to come up with. What are possibilities? How do I get back into my house? I've been locked up. So there's 4 categories of cognitive, and rather than teaching a class on it and overwhelming individuals, let's just get one solid point. What we want to try to do is represent in screening or testing for every one of our clients something from each of these categories so that our programming can be person specific.
I love that. And I'm going to add that cognitive to me in this context includes stress and emotion. So my same patient that I just talked about, he said, gosh, I've been more off balance, the last week, and I don't know why. And I'm like, well, what's going on with you? And he's like, well, I did get that call from my nephew and he's not doing well and he's in the hospital. And I'm like, yes, like now you have this emotional stress kind of taking up space in your brain, being like, gosh, is he going to be okay? And should I go visit him? And this and that, right? So like that is going to potentially affect balance. And I know that some people might have a hard time connecting that, but I see it again and again in my practice.
100%. Yeah. And that's where we talk about on the slide there, the internal thoughts and sensations. And you're right. It can be person specific. Like I mentioned, I have fear of falling, or it can be thoughts that you have that are distracting you about other people. Internal thoughts, perseverations, and ruminations all fall into that category, and it can be extra personal.
Absolutely. Good. All right, so let's talk about screening. This is important. How do I test this? How do I know if my patient is having this issue, or how might I have a hint that it's going on? Maybe I hear some things in their report, but let's talk about kind of actual tests that exist. What do we got?
Well, and let's start off with the very easy one, cognitive tug. Everybody knows that one. Everybody knows it's, serial subtraction by 3. And the things that we are starting to expand our universe with is that we should be able to become a little bit more person specific with all of our layering of cognitive motor interference. Because remember, math is either irrelevant for some people, scares some individuals, or don't forget, is way too easy for some people.
Yes.
I mean, Helena, I can't spell words backwards. If you were to give me a 5, 6, or 7 letter word, I'm very incapable. I have no fear of it, but I'm very incapable. However,
Sure.
if you told me subtract by 13, 17s, 19s, I don't care. Just give it to me. I can easily handle that. So we have to think about being person specific for our screening, that it doesn't cause them fear, that there's not an educational or ethnic bias that we're delivering, or that it's not so easy for them that we're not actually loading them. So that's when we get into this slide that, calculation's great, it's standardized, it's normative, but having them create a list, or having them, as we do, if we go down to the 4-square step test that I've got referred here in bullet point number 3, you could do a 4-square step test, single task, then while seated, say, can you, and let's say their favorite topic is birds or trees or NBA basketball or, NHL hockey. You find out what they like, okay? And then you say, can you generate a list of 7 items as quickly as possible out of that list? And they say, ducks and turkeys and chickens and geese, and they do birds. And now you have them do the 4-square step test again, and you have them try to list, 7 different birds while they're doing the 4-square step test. So we don't have it standardized yet. We're moving in that direction, but everything should be replicatable, should have a solid methodology. And believe me, it's always going to be most representative when it's person specific. So have them pick a topic, have them create a list, and use that list is a nice, intervention that I can hand your audience.
That's great. No, I totally agree. And then, of course, you do mention in your slide here about the SCAT-6.
Mm-hmm. Yeah, so this is beautiful. I mean, in 2022, it took this long, but it's here now, that a multidisciplinary worldwide consensus statement says, hey, if we're really going to screen if these persons have had a concussion, which is the reason why we have a sport concussion assessment test, then maybe we should be considering if these individuals are able to do a task before we return them back to the field today. And so they're actually doing a tandem walk test, 3 meters, and then they're also doing that in dual task version with serial 3 subtraction. So I love the fact that they've arrived at that. It's high level, it's got some intensity. Is your balance proficient? And does your balance demonstrate degradation when we load it with cognition? Because if you can't do this on the sideline, you're not going back out there when things are moving at 20 mph.
Absolutely. Absolutely. No, and I think it's great to think about, say, okay, I have a patient who could never do tandem walk to begin with. I scale it back. If they're still ambulatory, we think about a tug, right? So you're trying to figure out on the physical and the cognitive side, even if it's not a totally standardized test with norms, at least you can compare within person and try to see if you're noticing a big change. Would you agree with that?
100%. I conduct research on dual tasking. I know methodology and what we need to do to make certain that we're not biasing a sample and to make certain that we have fidelity. However, in the clinic, when we're trying to measure against a person and we want to determine if this individual has improved, you have the opportunity to do a 4-stage balance test if you want. stand still in whatever position they can barely handle, stage 1, 2, 3, or 4 for those individuals that aren't as familiar with that, and see their single task, load them with the dual task, and look for a difference on that. So, you can run a Berg balance test with and without distraction. You can do any number of activities. You could do a 30-second sit to stand test and put them on cushion with their eyes closed if you wanted to. 30-second sit to stand, eyes closed, on cushion, single versus dual if you want to. You can get very high level with this. And the SCAT is just doing the tandem because we're talking about sport and high level individuals. So you can break it down or up however you like.
That's excellent. All right, so I pulled this slide as well from your slides, talking about kind of how do we start? How do I kind of get from, something really involved, but maybe I can't start there with my patient?
Yeah, absolutely. So the nice thing is that when we start with something that feels familiar to the patient, they're more likely to get that optimal theory of motor learning benefit from early wins, right? Okay, this feels familiar. This is something I expect myself to be able to do, and do it in a single task fashion, whether that is, unloading a dishwasher in this situation with the rotation involved there. Do the single task physical first, things that are overlearned. You don't want to start a novel task. Can you go through this agility ladder and you've never done this in your life and also superimpose something else? No, go with real world familiar first, steadily add practical everyday distractions that this individual might have. What's your cat doing right now? What's the, you're on a phone call on a speakerphone with your daughter. What did she just tell you about her 7-year-old's day at school? So you could easily do something like that. You set it up. It's real life. You give them an auditory background, and then you say, as you were doing that, we completed it. How do you feel like you did? And can you tell me anything that you remember from that story? So we use overlearned tasks, and we gradually add the element of distraction that they appear intolerant of, ask for the patient's feedback, take a measurement, and we look to see what kind of symptoms we might have provoked from that overload as well.
Right. And I think that something that comes to me a lot from clinicians is, well, they're telling me that they got lost at a store they know well. How can I work on that? I don't have a store. I just have my clinic. And it can be difficult sometimes to replicate kind of the real world challenges, but we can get creative. I've certainly set up with just a bunch of chairs, and I stood up my floor mat as like if it was a wall, and I tried to create kind of a bit of a path that they had to find their way through. So you can try your best to create kind of some version of a real world challenge.
Yeah, no, that's a great idea. I love that. And you could actually even subject them to an easy cognitive distractor by walking and say, now walk me through your grocery store. What aisle do you go down first? And as they're talking to you about their grocery store, they have to visualize it. It creates, that VR type of experience. And now they have to say, tell me what you put in your shopping cart. Okay, so grab something from that aisle. And now they have to keep track of what's in their shopping cart. So you have a very practicalized manner of being able to replicate exactly what you just brought to our discussion there. You could definitely have them build that working memory. I grabbed celery from here. That's right. Okay. And I grabbed Coca-Cola from there. Yes. And I grabbed saltine crackers from there. And that's nice to just steadily load them, and it feels person specific.
I love that. All right. So one thing that's out there that is maybe a more common cognitive test I've seen for someone who's complaining with spatial concerns, which again is a big thing amongst folks with vestibular issues, is the trail making test. So we have our basic where you trace around, to the numbers in order. And then they have an alternating part B, which is going 1A to B, 3C. And it's all over the paper, typically on an 8.5 by 11. So You had an interesting option that you self-created, I believe, which is kind of trail making months. Could you explain that version for us?
Yeah, so this obviously came off of a twister board idea, and we first built it on a twister board and used black magic markers to write on the twister board. And so we did trail making on one side being dot to dot, 1, 2, 3, 4, 5, all the way through to 24. And then on the other side, we ended up doing 1 January, 2 February, 3 March, 4 April. We created another one of those that is the 1A, 2B, 3C, 4D. And now we've got them so sophisticated that we've printed them out on a canvas. It's a 5x8 sheet. I can give any of your audience the printing company that does this. I have no financial relationship. And we have now completed, data collection is done in our research project. I'm blinded to it because I was the primary examiner. We are looking at the 1A, 2B, 3C version of this in comparison to a person's performance on the cognitive tug and in terms of their performance on a paper pencil trail making. And we're looking to see which is the superior tool to, in fact, predict falls that they've had and predict falls that they're going to have. And so by CSM next year, I'll be able to tell you what the data says. Right now, I'm still blinded. They're in 6-month follow-ups right now.
So in real life, if I were to try this with my patients,
yes,
I could have them, they're going to walk and they're going to stand on the 1, and then they're going to stand on January, and then they're going to stand, right? So they have to
There's a lot of turns. There's turns in
I
there.
love that.
Yes, and you could take it with your, Mopo dots or whatever you've got, and you can label them if you want. The mat is very handy if you'd like. And the thing about this is that we put the order of the 1 January to February in the same exact order that the trail making paper pencil test is built. So it's not like the two are ever close to one another. We put them in the same fashion. So when we're testing one against the other, it's the same type of travel time. So this is the trail making agility test.
I love that. And in addition, of course, my mind is already going ahead. I'm thinking, gosh, as a vestibular addition, I would possibly have them reach down to tap.
You could.
So they have to kind of do an up down with it if they have, a little sensitivity to up down.
Yes.
You could go, kind of change up. Okay, now you have to go backwards. 12 December.
That's right.
11 November.
All of that works.
Yeah. And the cool thing is that it makes it scalable. So depending on your patient, if you have that kind of a baseline ability to communicate and so forth, you really have a pretty good breadth between, I've had, somebody who has a master's and a PhD, and, I just can't give them super simple cognitive challenges because it's not a good match. And it's not to say that someone who, isn't, sometimes I've had somebody at that was that level and they had a really major vestibular issue. And now we really have to make it a lot simpler and then build towards what I think they should be able to do. So it's really great to have breadth so you can meet everyone where they are and kind of try to bring them where they'd like to be.
Yeah.
All right. So let's talk about Stroop, another popular way to challenge some cognition. Not great for someone who is colorblind.
That is correct. With full sensitivity to being colorblind, we have created the same mat for the Stroop test. On one side of it, all of the words are written in the color. So the font and the words correspond to the same color. Yellow is written in yellow. But on the other side, we try to see how quickly they can go through when they are incongruent, which is exactly what's known as the Stroop effect. And this is the Stroop color word test. And we did this in an agility fashion. So how fast can you step through them? You go up a column, then you come down a column walking backwards, up the next column and down the next column. And so that is also another 5x8 sheet. It's even more word pairings than what you see here on this, but it's challenging. And we do that for a lot of different patient subtypes too. The looking down can be challenging for some individuals. They can memorize a couple and look up and give themselves a break. I love your iterations, reach down and touch. If you like, every time you see red, reach down and touch it. However you want to layer that.
Yes, and that allows us to go into a little bit of go, no go, which we're going to talk about more, which is something to the effect of do something for one, but don't do it for another. So maybe reach down only for red and blue, but we never reach down for orange and black. And so you can kind of make up rules that they
Yeah,
have to follow and
sure.
really get them thinking and trying to remember what were the rules. And I've done things with color when the person is not colorblind, where I will have them go in color order. So from the
Mm,
rainbow, which I've learned
yes.
some people, that's not something they learned in kindergarten. And older folks seems to be not a thing. So like, what do you mean rainbow order? And I'm like, oh, so, you have to fit it to the individual, but that's okay. We can always go with alphabetical by the first letter of the color. So there's lots of ways to add another challenge.
Yeah, that's great. And again, ultimately, we want to be person specific, respecting their educational background, etc. And then we want to layer into what's engaging for them and what is, environmentally relevant for them.
100%. All right. So this is a bit of a math problem, but it's a way to help us figure out for an individual where we don't have some sort of pre-normed test, right? So we don't, the cognitive tug does have some norms, for example. But
Mhm.
for those who aren't familiar with the tug, by the way, it's a timed up and go. You have the patient get up, walk a short distance, have to make it basically a U-turn, turn around, come back and sit in the chair. So we add a cognitive test to that. That's a physical and a cognitive combo. So here, if we were doing a cognitive tug, instead of using norms, we could simply have them do the tug by itself, right? Get up, walk, turn, come back, sit down, versus when they have to do some sort of cognitive task while they're walking and turning. And so that's the dual would be the good of the two tasks, and the single would just be the motor task by itself in that example. And
Yes,
then you
yeah.
can apply this to anything. Is that right?
Absolutely. So if my single task four square step test is 10 seconds and dual task while listing WNBA basketball teams, it takes me 15 seconds. Then it's 15 seconds, subtract away the 10 seconds, divided by the 10 seconds. So it's 5 seconds on top, 15 minus 10, divided by the 10 on bottom. It's a 50% dual task cost. It's very simple.
Awesome. So, a goal that we could make around this is reducing the demand, and that would reduce the percent. Is that accurate?
Exactly. So that just gives you something to document. The patient will exhibit a normal level of dual task cost for walking in an external environment, whatever the case may be. Patients currently at high risk for falls when distracted. Berg balance score is 51 in single task and 41 in dual task. Any number of
Hmm.
ways to document objective gains and need for continued skilled care can be corroborated with this.
So then, what's the norm? So, like, what is expected? There's going to be some cost to anyone, right?
Yes, absolutely.
So, what is that normal-ish?
Okay, so there's a big argument. It's not a huge argument. It's not a big controversy about this, but we don't have a perfect science for it. The best test says 10%. Now, I know
Okay.
Faye Horak personally, and I think that she would revise that at this point. And I think we all know that 40% is too much, 10% is a little bit too
Vicious.
light. So
Yeah.
somewhere in there, and it's going to be a little bit different depending on how novel the distractor is for this
Mm.
individual. So give yourself some latitude and go all the way right back to what Helena said about 15 minutes ago. Compare the person to the person. They're objectively getting better. We get concerned if it gets more than 40%. We're not too concerned if it's 10%, somewhere in there. But ultimately, we want the person to be getting better compared to themselves.
So, if the cost is 80%, and then we can get that number down to 40%, we're pretty pleased.
Yes, ma'am.
All right. Love it. Okay. So, these are a bunch of examples. We're not going to read them all out, but this is just kind of to help your kind of mind turn a little bit. If you're like, what tool tasks could I try? What could I ask, about what's difficult? What, might be difficult that I could kind of maybe check out and see, like, can they stand there, keep their balance and zip their jacket? Yep, no problem, great. Or, oh, I saw them struggling and they kind of were leaning to one side when they were doing it, which I've definitely witnessed. So we're looking at those things, right? And a lot of these don't require expensive equipment. This is stuff we could, have in-house, or maybe they have even with them like a jacket, right?
Yeah, you do not have to do any of these in body weight support. It can be over ground. Let's see your video here. This would be excellent.
Awesome. Yes. So this is a video. Some of you might have already seen it, but this is our patient. They are tapping a balloon, which is perhaps, you might argue, not a specific functional task, but it's important for this person because they're an athlete. And so eventually they're going to have to handle a ball. But I wanted to take it to a lighter level, something that couldn't hurt if I accidentally kind of tossed it and hit myself in the head with it, frankly. So I wanted to keep it really light for my post-concussion patient. And so I have them tapping this balloon, but notice how many turns I'm having them do. And they had to walk forward and backward. And underneath their feet, I have pool noodles under a floor mat. So it really is an uneven surface for them to negotiate, because in this case, they're playing lacrosse, something like that. I want them to be able to handle that uneven ground. So there's a lot of factors here.
2 thumbs up for me.
Okay, good. Awesome. Right. So we also have a list here, in addition to manual ideas that we saw on the last slide, cognitive ideas. So you have quite a few wonderful examples here. And I love that you really would make it individual, because I can tell you there's folks out there that wouldn't know a single sports team. And then there are folks who know every sports team, right? Absolutely. So good stuff. And then we have our visual challenges. Now, a little caveat for folks who are dealing with patients with vestibular issues. Some patients are what we call visually dependent, which means that they've kind of learned to utilize their vision heavily and overweight the importance of visual input. So these folks can be sensitive to visual motion or patterns, things like a checkerboard, things like that. So when you think about a visual distraction, sometimes we need to introduce that, but we need to think about when, how, and again, grading it carefully so that we don't overstimulate, especially in a patient with vestibular migraine. If they're not fully medically managed, that could be actually a trigger for migraine, which isn't like you're harming them, but it's not really going to help them. So you have to kind of use your good judgment on how and when we decide to habituate visual stimulation that way. But here in this slide, there's plenty of gentle vestibular visual challenges that you could create here, where someone is working like a puzzle, something like that, and having to turn their head to get the pieces, that kind of thing. So there would be ways to integrate that without overstimulation if they're not ready for that. Would you agree?
100%. Yeah, it's great. And I love, in every single slide that we've covered today, I love how you're respectfully considering how to grade it up or down for any individual. So I just continue to endorse the fact that you're thinking about vestibular with visual sensitivity, et cetera. Great job to be thinking about person-specific response.
Absolutely. And I know our audience, many of those who are working with patients with vestibular issues, it's something you're familiar with, or it resonates with you. So just kind of the challenge that I've run into as a newer clinician, and I think that many people run into, is kind of, how do I know when or how? And then sometimes we do accidentally kind of maybe do a little too much, and they take a little longer than we would like to settle from their symptoms and such. But, you just got to do your best to grade that, right?
You do.
Then, of course,
one quick point on that. One quick point on that. It's very important that when we've over-provoked someone, we don't say, okay, you know what, that's, sorry about that, let's move on. It's important that we see them as an individual, and we take a moment to stop and say, this is very important that you're willing to give me that feedback, because that helps me make my prescription for you, my approach for you, that much more accurate. So keep coming to me with that feedback. I want to respect that. And we will build your program with intensity and reduced intensity accordingly. So thank you. I always want to, just when they give me feedback that can feel like hey, do you have any idea what you're doing? That was really challenging for me. I always want to take a moment, hear them, see them, and tell them, we're going to make it more specific according to what you told me.
Yes, yes. And I'll encourage folks. So some folks are kind of like, just like with pain, like they're like kind of don't want to tell you that they've had symptoms or that it's kind of stronger than I want, right? And my rule of thumb is I don't want more than a 2-unit increase. And I really emphasize that to my patients. So if they're coming in at a 2 out of 10 dizziness level, and we're going to do something stimulating, a little challenging, some turning, some reaching, if you're noticing, and they might not notice the symptoms because they're distracted. So it's kind of a pro and a con there, perhaps. But, try to pay attention. If you're starting to feel, more than a 4 out of 10 dizzy, we need to kind of slow it down or take a moment, reset button the brain, I call it, just kind of let things settle. And that's going to allow better processing of the movement than if we just kind of load them up, in my experience, and really elevate them in a way that they end up being prolonged in that elevation. They're 7 out of 10 for the next hour. That's usually less helpful or less effective than if we kind of grade it gradually and adjust per session. So one day they did great. They really tolerated a bunch, but then they had a poor night's sleep before the next session. And they're like, gosh, I really feel rotten coming in. We better not just try to kind of progress. You're going to maybe kind of adjust, modulate what you're going to do with them, maybe do a little more neck care or something else.
Yep, that's great. And they always know that you're collaborating with them dynamically with how they are today.
Exactly. So you have some nice auditory examples of dual task here, whether that's kind of being able to recall a grocery list. This is my Apple Table Penny. For those of us who use the Mocha ever, have you used that before, Dr. Studer? Are you familiar with that one?
I typically go pencil, clock, tree are my go-to.
Yeah. So it's just 3 items to remember at the end of the test, because there's been intervening activity. And I love the idea of, kind of in someone with some cognitive challenges who's reporting that to you and wants to work on that. You can say, hey, I'm going to give you 3 words at the beginning of the session. Halfway through, I'm going to ask you what they are. It could be a good little litmus test, good little challenge. And if they're successful, that's a nice, hopefully easy win. So, think about integrating those things also into your session, which is not a cognitive task within hold your balance. It's just a kind of, hey, I'm going to kind of toss this into the mix of the session, right?
Yeah. My favorite thing on this is to go person specific, and I force myself into a little challenge. Okay, you tell me your topic of conversation. I will come up with things inside that topic of conversation. So now when they tell me different species of fish, now I am going to give them the auditory, but it's going to be in their wheelhouse of what they like. So it's totally different than them generating that list. I'm giving them the list, but at least it's engaging. And I say it's a bass, salmon, carp, yellow belly, etc. And now they have to actually hear that, and they're engaged by that, and they can feel relevant, heard, and personalized.
I love that. All right, so here's another video example. I kind of alluded to a version of this. So this is my patient who I more than dual tasked them. But what this case was a patient with blindness or near blindness who has vestibular migraine. Very challenging situation, because a lot of the strategies we use to drive down dizziness are not accessible to a person with limited vision. So I'm really upweighting their somatosensory. We're really trying to use her excellent cognition. She's very bright, to try to kind of accommodate sensitivity to movement, and some cognitive reports she had where she was like, I was like at the store I know really well, and I couldn't find my way back to where I know I was supposed to be my friends. And she felt very embarrassed by that. So we worked on, I had her carrying some shopping bags. I set up this kind of, like I said, kind of obstacle course type thing with the mat as the kind of the wall, and had her kind of weave around it. And then this example shows spelling words backwards, because her vision is limited. She doesn't read words the typical way. And so we ended up switching then to math, because it just wasn't right for her to work on the words, because it's not like she was dyslexic, but it just wasn't a good fit for her, right? So you have to kind of, again, accommodate, like you say. But I'll go ahead and show this one, so you can get a sense of that. So I had told her too, she had to step over certain cones, step on and off certain objects, go around other objects. And she had to remember which ones she had to go on and which ones she had to go around and which ones she had to go over. Now, this person, again, is very bright. She should be able to keep up with all this. So it was a lot for her to remember and think about, but she liked it. She felt like it really met her where she is, you know, kind of her capabilities and where she needed to be challenged. So it was great for her.
That's great.
U-T-S. Nice.
Perfect. All right. So leave that video and go to dosage. So BWS, I kind of defined it on one of the slides briefly, just for everyone who might not be familiar. It's body weight supported. It's a nice harness, usually attached to the ceiling, something really safe. So it's nice if you have it, but recognize if you don't, you're just going to kind of accommodate how you guard or what you set up, how hard or easy, kind of what leeway you have. When you have the body weight supported, it does give you a little more freedom to challenge them at a true intensity level, especially on the treadmill. So that's really cool if you have access to that. But if you don't, you can still make it work. Would you agree, Dr. Studer?
100%. Yes, we are built to protect our patients with gait belts and hands, etc. You'll always keep them safe physically and psychologically are the two parameters that I look at. But taking them, you know, out onto the soccer pitch and court and sidewalk, etc., is necessary. So we do take the more severely impaired patients initially with some sort of harness if needed, but ultimately reintegration into the world is what physical therapy is all about.
Awesome. So then you had several slides. If you're running out of ideas, just come back here. You got more ideas loaded up. I love it. Wonderful next level dual task, auditory distractors listed here. Beautiful visual ones here. I like go, no go, especially because it's like real life. And I think we should talk about that specifically for a second. Tell me about go, no go.
Yeah, so go, no go is essentially impulse control, which is a representation also of the inferior frontal lobe. Wait a second, I've got a cognitive set that I should be looking for threes or looking for green clovers. Hold on, now I have to pivot my cognitive set. Now that can be very gamey and fun for some individuals. And truly the reality is it okay to step here? There's a puddle here. There's some, dog poop that's been left behind here. The reality is every day's real world has go, no go. I'm going for that seat. Whoops, somebody else is headed for there. So there's always make a plan, adjust a plan, and, always looking at what the environment has dynamically changed in front of us is the crux of impulse control and decision make and cognitive set, go, no go.
Yes, and driving, do I go or not? Very classic, easy example.
Turn taking,
and
yeah.
So safety specific for driving. And then even in a grocery store, oh, I'm going to go to that aisle. Oh, no, wait, 3 people just went in that checkout lane. I'm going to go to this one that's empty, right? So you're kind of constantly, without realizing it, making go, no go decisions.
Yeah.
And so they've really studied this in the athletic population because it's really very much about, which way should I go? Oh, look, there's a defender. Let me go that way. That sort of decision making on the field, which could matter on a sports level, but also, again, on a safety level. We don't want these folks to be tackled on repeat and tearing their ACLs. So there's some beautiful dual task here on manual distractions as well. So you can utilize these ideas and cognitive distractions that get a little deeper. So just love the breadth of ideas we can have here. Don't get overwhelmed, though. Just kind of, again, use these as ways to kind of say, I have this patient coming in. What's their deal? Okay, they want to go back to fishing. What's a go, no go activity that could be relevant to that, and try to come up with something as best you can.
Yeah.
And I wanted to talk a second about this slide that you had on perceived difficulty. Tell me about this.
Yeah, so this is just a way to be able to consider the individual. Again, I'm a huge proponent of the optimal theory of motor learning. And so when an individual has autonomy and they get the opportunity to rate how difficult that felt to me with a dual task, it was difficult, it was confusing, it felt embarrassing, or that was too easy. Just like a modified Borg perceived exertion scale, have them rate the cognitive difficulty that they perceive. And then here's the part that's often left out, have them also select or operationalize what level of difficulty they want the next task to be. Okay, that was way too easy, but I need to keep it at way too easy right now. Or that felt really hard, but I liked it. Let's go with really hard again. So if we have a person rate something, what we often forget to do is to have them also insert themselves. What do you feel capable of, tolerant of? What do you prefer? So that they feel heard again.
100%. And in addition, I would add, some patients 0 to 10 is way too overwhelming in my experience. So I will often use easy, medium, or hard as a way to kind of get a sense, but to make it like a little more accessible to, these people who can't make decisions. You don't want to like give them like, is it a 5?
I have this in a 5 color. I have that in a 5 color as well for any of your audience that wants that in just 5 as well.
There you go.
Choice burden, the paradox of choice, is a real thing.
It's a real thing. And the other thing about it is I will sometimes get a little more information. So they'd be like, I would say that was medium. And I'd say, they're like, well, it kind of felt medium and kind of felt hard. I'm like, well, what about it felt easy? What about it felt harder? And maybe they're like, well, the balance piece wasn't too bad, but I really had trouble, figuring out the puzzle, right? So it's really nice to kind of get a sense in a dual task situation, what parts felt easier or harder.
Yeah.
All right, this last little piece, and then we'll wrap it up because I know we're over time as usual because I always have so much to talk about because it's so interesting. All right, for cognitive operations, you cover this: hold, process, recall, generate. So let's talk about each of these types and start with hold.
Yeah, so hold is very simply a more practical way to talk about short-term or working memory. I'm going to give you something, and in a moment, I'm going to ask it back from you. So that's hold, but we gave you great examples, sport-based and community-based for both, and you can turn back to that.
Beautiful.
Process is having to manipulate something. So do I have enough gas to make it to? Are we going to be late for? How much time will it take me to? What's the best route for? I've been locked out, and what are some possible options? So process takes some manipulation.
Awesome. All right. So here, I wanted to show this video as our last video here. Nice example of actually a go, no go dual task. And so the person has to step the direction they're catching, and then there's a clinician who's calling out opposite or same. So if they call out opposite, they have to catch the cone, the beanbag with the cone that's the opposite color. If they call out same, they have to catch the beanbag that was tossed with the same color. So there's some processing there. And they've been set up safely in the corner with the chair in front for their level of balance. So thoughts on that?
It's great. It's intense, just intense enough. I got to concentrate. And it's safe. I love how you've built the constraints of safety there. So it's wonderful. And again, 2 thumbs up from me.
All right, good. All right, so we've hit up process and hold. What about recall?
Recall is just, can you generate something, pull up something from your long-term memory? So hold is short-term memory. I'm giving you something. Recall is name 5 different pets you've owned. Name 5 different classmates from high school, or 5 different cars you've driven. So recall is just a different aspect of cognition.
Awesome. All right. And last but not least, generate.
Generate. Give me as many different NBA teams, fish, birds, trees. What's your topic? Generate as many as you possibly can. So it's creating lists, and it is also innovating. Okay, I've been locked out of my car. What are 3 different ways I could possibly get back in? My wife has a key. My phone app can automatically unlock it, et cetera, et cetera.
Awesome. Love it. All right. Last but not least, in a general sense, I am not a cognitive therapist. I am not a speech therapist. I am going to work on cognition. Absolutely. 100%. Makes it more interesting, makes it more relevant, really helps with balance. But I think this patient has really significant cognitive issues that are beyond my scope. Who should I refer to? When should I refer to? When should I refer? What are my decisions here?
Yeah. So when we have an individual that has a diagnosis that could be reimbursed by, that's one consideration. It's not the only one. So if it is a vestibulopathy, are we going to be able to get SLP justified? Are we thinking about that? Concussion, maybe yes. So part of it is going to be what's available. Part of it's going to be what's going to be paid for. What's the ultimate goal? So neuropsych, I want this standardized. I need to be able to determine level of disability for someone. I don't need so much assistance with programming, but I need to determine what attributes of cognition they have that are challenged. But I might go over to speech language pathology if I want a collaborator and I want a colleague that can also help to reinforce, can help to breathe into my programming. I might go that direction.
Awesome. All right, perfect. So, kind of take home message to me here is sometimes we don't have resources where we are living or what have you, and you just have to do the best you can. But we are not designed to do everything, whether we're a physical therapist or an ENT or an audiologist. So we want to have ideally a team when the patient needs more than one team member. So do be thinking about when it's appropriate to refer and, who you could refer to and when for things like speech therapy or neuropsych evaluation.
Yeah, you've got the take home 100% there.
Yes, because safety. All right, awesome. So this is our guest. Fantastic, wonderful, lots of ways to find him and his wonderful resources, including, but not limited to, his awesome book, The Brain That Chooses Itself. Highly recommend, as well as ways to take courses from him on MedBridge. He has a clinic in Oregon called Spark, and he is a part of a group, Marbles. So I'll give you 30 seconds to talk about Marbles, and we'll wrap this up.
You know what? Thank you so much for the opportunity. Marbles is actually just a brain gym for persons with impairment or persons seeking wellness. And so we do high-level dual tasking, and there are franchises opening all over the United States. We just started last year, and it's a wonderful tool to actually have some way to address cognitive impairment.
Fantastic. So this is in-person gym, or are we talking online or
in-person gym? Yeah. And it
awesome.
is equipped with the latest of dual tasks. So it's got all the smart fits and DV dots and cyber cycles, plus low tech stuff that I've created for the programming.
Awesome. So if you have a Marbles in your area, it could be a great way to, if I'm a physical therapist seeing a patient, I'm ready to discharge, but I'd like something ongoing to keep my patient going. This could be a great resource. Would you say so?
I would say so. And if you are looking for a Marbles in your area or want to find out where they are, just email me. It's no problem.
Fantastic. All right. I don't think I put your email up here, but
and it's just mike@mikestuder.com. So
there you go. Nice and easy. I love it. All right. Well, thank you. Thank you for being our guest. Thank you for this discussion on dual task as it relates to vestibular rehabilitation. Really appreciate your insights, and I hope everyone enjoyed it.
My pleasure. Thanks for having me as a guest.